Hi everyone, welcome to today's webinar, PRRT 3 years after its introduction in the US, where we are and where are we going, with Dr. Lisa Bodei. I'm Lindsay Judovine, the Director of Communications for LACNETS, and this is...
I'm Lisa Yen, I'm the Program Director for LACNETS.
Before we get started, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. You're the best, Rich. We will be having a live Q&A following Dr. Bodei's presentation. So to submit your non-case specific questions for today's speaker, go to www.slido.com and enter event code LACNETS4. Here are a few tech tips for today's webinar. For your audio, please be sure that the volume on your computer is turned all the way up. Also double check that the volume is unmuted on the webinar broadcast screen. For the video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. Also, please remember the full webinar will be posted on our YouTube channel a few days after the live broadcast. We also have 100+ net videos you can also watch. As a reminder, these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. Also, one last reminder before I pass it off to Lisa, please follow LACNETS on social media. We have Facebook, Twitter, and Instagram. You can find us at LACNETS. And now, off to you, Lisa.
Thanks, Lindsay. LACNETS is a program by GeneratePossibility.org, a registered nonprofit, and LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer, since we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are in fact led by a team, which includes our interim administrator and board member Kavya Velagapudi and board member Donna Gavin, who is also the sister of LACNETS founder and executive director emeritus Giovanna Joyce Embracey. Our newest board member is Mary Dunleavy, who is living and thriving with NET. I'm excited now to introduce today's speaker, Dr. Lisa Bodei. Dr. Bodei is a board-certified nuclear medicine physician from Memorial Sloan Kettering Cancer Center in New York City. She's the author or co-author of more than 160 peer-reviewed publications, and she serves as editor for multiple scientific journals that are important to the NET community. She's treated thousands of patients with PRRT and is very active in NET research and the NET medical community as a whole. I've heard Dr. Lisa Bodei speak countless times at both patient education conferences and meetings, as well as medical conferences. Her knowledge and experience with Theranostics and PRRT is incredible, and we're excited to have her join LACNETS today. Before Dr. Bodei's presentation, we will first hear from someone living with NET who was diagnosed last year during the pandemic and underwent and has completed PRRT. So let's first welcome NET patient Denny, followed by Dr. Lisa Bodei.
Greetings, my name is Denny, and welcome to my garage. LACNETS has invited me to talk a little bit today about my journey with NETs, as well as share my experience having recently completed PRRT. So first, a little background on my experience with NETs. I was diagnosed in June of 2020. I had symptoms starting in January of 2020, flushing and unexpected weight loss. And in June, finally went to my doctors for some workups and determined that I had near confluent, too numerous to count lesions on my liver. I had about 3 weeks to wait between that diagnosis and actually seeing an oncologist and learning that I indeed had NETs. I'd had a biopsy in that interim and determined that there were NET neuroendocrine tumors across my liver, but no primary. They couldn't find a primary tumor, still can't. And I had a Ki-67 score of 22.4, which meant I had a high-grade tumor, but just into the high-grade area, which meant my tumors were progressing. That was a shock, as I think it is for all NET patients when they get their diagnosis. I'd been healthy my whole life. My wife and I just could not believe that I had cancer. But quickly for me, what worked was to get as much information as I could and do as much research and learning as possible to be my own best self-advocate. And I struck out reading journals, reading everything I could put my hands on, watching videos, going to virtual conferences, and joining 3 support groups up and down the West Coast. About this same time when we talked to my oncologist and also a second opinion oncologist in Seattle, we live in Northwest Washington, they both suggested starting me on lanreotide, which I did, and talked about PRRT, but talked about it in some distant future where that might be appropriate for me later on in my therapy or my treatment. And almost like it was a potential last resort therapy versus a treatment that could come earlier on in my cancer. So again, in my research that I was doing, I also discovered a video from the Carcinoid Cancer Foundation, the Lunch with the Experts with Dr. Maudlin, talking about the NET test. And I was curious about the NET test just because of how that might be an additional marker that we could track on this journey. And so I contacted Ren Labs. Dr. Maudlin actually contacted me back, and we talked further, and as well as sending me or giving me information on the NET test, he also asked if I'd considered PRRT earlier. And he said, well, don't take that off the table right yet, because he thought that could be a good first line or close to first line treatment for me. So I put that in the back of my thinking cap and also continued to do more research on PRRT as I continued my learning journey. One of the things that I learned also with my research was that it's a great idea to have a NET specialist oncologist leading your team. And I did not have a NET specialist oncologist. I wasn't even sure how many NET patients my oncologist here had seen. So I changed. I found a NET specialist in Seattle and began to see him. His review of my scans in medical records, he came to the same conclusion that because of my unknown primary, because of the numerous lesions on my liver, I also had another metastasis in my mesentery. He thought I was a good candidate for PRRT. So when he asked, would I like to start PRRT now, or should we wait a few months? I said, let's go now. So about the same time, I had yet another learning through my research that it was okay to have more than one doctor and more than one NET specialist on your team. So at the encouragement of Dr. Maudlin, he suggested I get in touch and referred me to Dr. Bodei as an expert in PRRT that could benefit me in being able to answer questions and advise me on my journey with PRRT at this part of my treatment. So I contacted Dr. Bodei, she agreed, and she's been a great resource for me, not only also agreeing that PRRT would be a good alternative for me at this point, but being an advisor with the NET test, which I was curious about. I've had 5 of those now, and we review each of my NET test results, and she provides feedback and I ask questions. So I found that it is great to have many doctors on your team, and when they all collaborate together, that's an excellent thing. Now that my PRRT treatment is completed, I have to report that the treatment itself was fairly easy for me, And everybody is different. We're all different. All of our diseases present differently. I feel great. After the first treatment, my symptoms completely went away. I no longer had carcinoid syndromes of flushing. I began to gain weight, began to get energy back, and feel more myself again. Time for hobbies like my old cars, like the tomatoes growing on a shelf to my side here. I'm a gardener, I'm a car guy, I'm also a hobby photographer, and have energy and time now for all of that. So it's been good for me, and the goal with the PRRT is always stability of disease. In an interim scan we did between treatments 3 and 4, it appears I'm also going to be a lucky one that has some reduction in my tumor load, and that was especially important to me in my liver. So my takeaways from this is to all of you and all of the NET patients, there is hope. We're all different, we're all going to respond to treatments differently, but everyone says, this is much more a marathon than a sprint. And I look at this with a long-term view of how can I have the best quality of life for as many years as I possibly can. And hopefully that will be many, many years. My message now to everyone with NET cancer is there is hope. I believe there's hope for all of us. I have seen and talked with many, many people who have learned to live with this and learned to live with it very well and very fully for many, many years. And my hope and my intention is to be one of those NET patients. Thanks for listening.
Good afternoon. I would like to thank the Los Angeles Carcinoid Neuroendocrine Tumor Society and the organizers for inviting me here today to give a lecture on the status of PRRT today, 3 years after its introduction in the US and where we are going. I would like to briefly introduce myself. I was born in Pisa, where I started my career in nuclear medicine, which I then developed in Milan at the European Institute of Oncology. And then for the past 5 years, I continued my career at Memorial Sloan Kettering in New York. This is my disclosure. So, Theranostics. Today we talk a lot about Theranostics. Theranostics are molecules that are both diagnostic and therapeutic. So that's the combination word. So they are molecules that have a specific attraction for cancer proteins. And these molecules can be tagged with radionuclides through specific holders, which are called chelators. And the radionuclides can be either diagnostic or therapeutic, and this can allow us to either detect or treat the disease. So when we use diagnostic isotopes, which we generally detect with PET, we use Theranostics to localize the extent of disease, to monitor the response to therapies, and to select patients for therapy. And this is their unique characteristic, which is that Theranostics allow us to identify specific biological characteristics of the tumors and their environment, and then to treat them systemically, which means that we can treat the tumors wherever they are. So with somatostatin receptor theranostics, with neuroendocrine tumor theranostics, we can detect the location and the extent of neuroendocrine tumor disease. So when we switch to the therapeutic phase, with Theranostics, we can target the disease and then we can visualize the strike, or as we say, we treat what we see and we see what we treat. So PRRT, what is PRRT? PRRT, or peptide receptor radionuclide therapy, is a systemic treatment which consists in the administration of a radiolabeled octreotide. The treatment is fractionated or divided in multiple cycles, generally 4, and is administered together with solutions of amino acids to protect the kidneys. PRRT behaves like a Trojan horse. The mechanism of action relies on the delivery of the radioactivity through a radioactive somatostatin analog inside the tumor cell, where the radioactivity can remain trapped and can hit vital targets such as the DNA. So what are the lessons that are derived from over 25 years of clinical trials of PRRT in neuroendocrine tumors? There are numerous single-arm studies over the past 25 years that demonstrated that PRRT is an efficient treatment with substantial objective, so tumor responses and symptomatic responses, impact on survival parameters. PRRT is also well tolerated with manageable acute side effects, including nausea, fatigue, and pain. Subacute hematological toxicity is mild and reversible in the large majority, and chronic and permanent side effects such as renal failure and myelodysplastic syndrome are rare. And currently, lutetium dotatate is the mostly used radiopharmaceutical and the approved one. And here you can see an example of a patient affected by a large pancreatic mass that you can see on the top right of the slide with a liver metastasis, image top left. And in the top row, you see the baseline tumor characteristics, and in the bottom row, you see the response of the tumor after the completion of PRRT. So what about symptom control after lutetium dotatate? There are various retrospective studies which demonstrated that PRRT is able to induce a significant symptomatic improvement in the majority of patients, regardless of the tumor response. And also in the ad hoc evaluation of the NERO-1 trial, there was a confirmation of the benefit in the symptomatic domains associated with neuroendocrine tumor disease, such as the global health, diarrhea, the pain, and the flushing. And what about survival? Survival after PRRT is longer in those patients acquiring at least stable disease, stabilization of disease, which means that disease control after PRRT has an impact on survival. And what about permanent toxicity after PRRT? This is low and comparable to other treatments. In our series of 807 patients that I treated when I was at IO in Milan with Y90, lutetium, or Y90 and lutetium peptide combinations, we observed no severe renal toxicity in patients who were treated with only lutetium dotatate. And regarding bone marrow toxicity, the incidence of pre-leukemic conditions such as myelodysplastic syndrome was about 2%, 2.3%, some of which unfortunately converted into overt leukemia, but these data were comparable to the same occurrences happening after alkylating agents. So who are the candidates for PRRT? So aside from the suggested indications that we wrote in the first guidance document ever prepared on the subject, which was then endorsed by the major scientific associations, the approved indications for lutetium dotatate in Europe is gastroenteropancreatic neuroendocrine tumors, G1 and G2, and in the US, GAPNETs, regardless of grade. The approved scheme is the classic NERO-1 scheme, which is 4 cycles, 200 millicuries each every 8 weeks. However, several recent iterations of the NCCN guidelines recommend considering PRRT also in bronchopulmonary and thymic neuroendocrine tumors, as well as in pheochromocytomas and paragangliomas. So let's explore the benefit in the various types of neuroendocrine tumor disease. So everyone is familiar with the NERO-1 trial, which was conducted in patients with small bowel neuroendocrine tumors, randomized to receive either lutetium dotatate or high-dose octreotide. So as everybody is familiar with this, in patients treated with lutetium dotatate, there was a longer progression-free survival, a greater overall response rate, which translated in a 79% reduction of the risk of progression or death in these patients. But what about the other sites of disease? For example, pancreatic neuroendocrine tumors. Non-controlled studies done in Italy, for example, Germany, and the Netherlands demonstrated that PRRT is a favorable option in these patients with tumor responses and impact on survival parameters. Also, non-controlled studies in bronchopulmonary neuroendocrine tumors done in Italy, for example, at my prior institution, in Germany and in the Netherlands, demonstrated that, again, PRRT is a favorable option with objective responses in the same range, about 30%, and impact on survival parameters. And what about patients with high-grade neuroendocrine neoplasms? So experience in this category is more limited. There seems to be efficacy, particularly in the well-differentiated forms. And obviously, if PRRT is to be considered, we should make sure that all the lesions express somatostatin receptors, so they are positive at the PET scan, at the somatostatin receptor PET scan. And also consideration should be given to either preliminary or concomitant chemotherapy. Obviously, the latter should be done within a dedicated protocol. So when should we introduce PRRT in the therapeutic algorithm of neuroendocrine tumors? So PRRT can be introduced in a whole range of situations, from end-stage disease, as the example on the left, unfortunately with very extensive disease to the bone and the liver, to the example in the center, which is a more common situation, or even adjuvant treatment based on biopsy-proven microscopic disease, and in this case also positive NET test. So a recent post-hoc analysis of the NET-1 trial showed that the presence of a large target lesion at baseline, even in the lutetium directate arm, was associated with a slightly worse progression-free survival, although the median progression-free survival was non-reached in both groups. So these results advocate for possibly an earlier treatment with PRRT. And how should we sequence PRRT? So at the moment, aside from mid-gut neuroendocrine tumors, where the algorithm has been defined by the NET-1 trial, all other algorithms are still empirical and reflect the local tumor board practice. Frequently, PRRT is still the last resort. And for example, even the NCCN guidelines, here the example of the pancreatic neuroendocrine tumors, indicate a number of therapeutic options, amongst which also PRRT, but they don't indicate how and when to introduce it. Hopefully, the COMPETE study will clarify the role of PRRT versus everolimus in GEP-NETs. So when should we use caution in PRRT? We are all excited about PRRT results, but obviously there are some situations which require our attention. Well, first of all, patients with a compromised clinical status. So those patients who are capable of only limited self-care, who are confined to bed or to chairs for the majority of the day, probably will be overburdened by PRRT, and either adaptive schemes or maybe alternative options should be considered. And then patients with mesenteric or peritoneal disease may be at risk for a small bowel obstruction after PRRT due to the radiation inflammation. So generally, steroid taper is administered as a prophylaxis. Also, patients with hormonal syndromes, for example, carcinoid syndrome, may have an exacerbation of symptoms, and this might be even serious. So prophylactic coverage, for example, with somatostatin analogs, and also prompt treatment should be considered. And what about hepatic toxicity? So there are some data from the university, the UPenn, that demonstrate that patients who previously received radioembolization with radioactive spheres are more at risk of developing toxicity to the liver when they receive PRRT or vice versa. This is different from what had been published previously in Europe, and probably indicating a different timing of introduction of PRRT in these patients. But obviously they indicate that, especially in heavily pretreated patients, liver toxicity, radiation toxicity can happen. So how do we perform PRRT? Patients, as everybody knows, are prepared with anti-nausea premedications, then start the 4-hour amino acid protection, and then, while receiving the amino acids, they receive PRRT. And the PRRT can either be administered through a gravity method or a syringe or a pump, and usually the administration runs for about 30 minutes. We like to obtain images after the treatment for quality assurance and for an interim evaluation to guide further imaging in case of need. And here, let me show you a classic example, a patient with a well-differentiated G2 pancreatic neuroendocrine tumor with liver metastasis. The patient is in progression after octreotide LAR. The patient is symptomatic for abdominal pain, fatigue, and weight loss. The lesions, as you can see, are intensely avid at gallium directate PET-CT. You can see the MRI image of one of the liver lesions. The patient is selected for PRRT. The patient completed PRRT with only mild and transient hematological toxicity. There was a marked improvement in the symptoms, in performance status, weight gain, and as you can see from the comparison of the pre-PRRT imaging on the left and the post-PRRT imaging on the right, there was a very beautiful response, so a substantial decrease in the tumor volume and avidity at the PET scan. So this is a beautiful response. I'll show you here in the next slide an example of adapted treatment. This is a patient with a well-differentiated G2 rectal neuroendocrine tumor with a liver metastasis, nodal and peritoneal metastasis, mainly liver. Patient has a reduced performance status and disseminated intravascular coagulation, which we suppose had a neoplastic cause. Platelets were 14,000, so this precluded PRRT. So in an attempt to bridge the patient to PRRT and decrease the neoplastic stimulus to this intravascular coagulation condition, we attempted hepatic artery embolization. At the first course of embolization, no change in the platelets levels. At the second cycle, after the second cycle, we noted an increase to 90,000. At that point, we saw our sweet spot, our window of opportunity for PRRT, and we brought the patient in. The patient was treated initially because of her condition with a half dose. And then as we moved along, she received the remaining cycles at the full dose. She tolerated the treatment well with a marked improvement in a clinical status, objective response, and no more intravascular coagulation status. And here you can see the comparison between the pre-PRRT images on the left, the lutetium images in the middle, and the post-PRRT images on the right. A beautiful response. So we have examined the current status of PRRT. What are we exploring for the future? So the currently explored approaches for PRRT and neuroendocrine tumor theranostics are several. A very popular topic is now that PRRT is an established treatment, is to define the place and time for PRRT in the therapeutic algorithm of neuroendocrine tumors. Then we have new strategies, which include combinations with chemotherapy, with biologics, with hormonal therapies, intraarterial routes. And then there are the new theranostics, such as the somatostatin receptor antagonist, the albuminated octreotide, and the alpha emitters. One of the most urgent questions now that PRRT is approved is to define a place for PRRT in the therapeutic algorithm of neuroendocrine tumors and whether we can improve the efficacy. So for the timing, a number of studies ongoing or planned explore PRRT versus something, some X treatment, where X can be chemotherapy, for example, with capecitabine, or best standard of care, or everolimus. And then there are strategies to augment the efficacy of PRRT by combining it with synergistic treatments. For example, chemotherapy, everolimus, immunotherapy, and so on. So let me give you some examples. for timing. There is the COMPETE study, which is aimed at evaluating the efficacy and safety of lutetium DOTA versus everolimus in GAPNets. The primary aim is progression-free survival. 300 patients are being randomized to either receive lutetium DOTA or everolimus, and the study is ongoing. Then there is the NETTER-2 study, which is aimed at evaluating the efficacy and safety of first-line lutetium directate plus octreotide, LAR, versus high-dose somatostatin analogs in G2, G3 gastroenteropancreatic NETs. And again, the primary aim is progression-free survival. Patients are being randomized to receive either lutetium directate or octreotide LAR 60 milligrams, one-to-one randomization, and the study is also ongoing. Another strategy is a neoadjuvant PRRT. The Rotterdam group has demonstrated that upfront PRRT in borderline inoperable pancreatic neuroendocrine tumors could lead to successful surgery in about 30% of the patients. And this was also reflected in a longer PFS. As you can see from the curves in the upper right portion of the slide, the yellow curve is the successfully operated patients, as opposed to patients who were not operated or the multi-metastatic ones. And the Italian Neuroendocrine Tumor Association is about to start a multicentric protocol on this topic. An example of augmented PRRT. The classic example is the combination with chemotherapy, or as it has been renamed at Peter Mac Institute in Melbourne, Australia, PRRT, or peptide receptor chemoradiotherapy, which has been tested in patients with aggressive disease. And this approach demonstrated to be effective and resulted in long progression-free survival. There are some long-term effects to further explore. If the advantage on one hand of this approach is to have a synergistic effect with radiosensitization and chemosensitization and to improve the response in rapidly progressive tumor, in this study from Peter Mac on 521 subjects, there is an increase of myelodysplastic syndrome with an incidence of 4.8% versus the regular 2.3% of standalone PRRT. So this will have to be explored to understand the role of prior therapies and concomitant therapies. And obviously, we need adequately powered, prospective, and rigorously analyzed studies underway. And which are underway because the group of Meldola, Italy, has a prospective randomized study ongoing at the moment. So intraarterial PRRT. The rationale of intraarterial PRRT is to exploit the first-pass effect, thus increasing the concentration of radiopeptide within liver lesions. It is an underused approach. As you can see, the data are scant. These are the data from the University of Heidelberg in a very small group of patients, but you can see that this strategy produces 60% of tumor shrinkage. Technology is sophisticated, it's indicated for liver predominant disease. Trials in the US are at UCSF, where there was a trial of monotherapy with Y90 DOTA, and we just opened a trial at MSK of multiple intraarterial and IV cycles. What about new Theranostics? A promising alternative radiopharmaceutical group is the somatostatin receptor antagonist, such as JR11. JR11 was demonstrated to have improved doses at the tumor site. And we conducted a study at Memorial Sloan Kettering in 20 heavily pretreated patients with neuroendocrine tumors, and we could demonstrate that we had a best overall response in 45% of patients with a progression-free survival of 21 months. These were really heavily pretreated patients. And there were some concerns about prolonged severe hematological toxicity in the first few patients, which was resolved once we modified the protocol. Obviously, these are promising data, but we need additional studies to determine the optimal therapeutic schedule and dosage. Another promising radiopharmaceutical is the albuminated dotatate or Abitate. There are previous studies conducted in China which demonstrated that this compound has a prolonged circulating half-life in the blood, which results in a 7 to 9-fold increase of the tumor dose delivery. And we have a phase 1 study underway at MSK. And finally, the alpha emitters. This is the data presented by Dr. Del Passan and co-workers at last LACNETS meeting. This is a first-in-human study of lead-212 dotamtate, which is an alpha-emitting form of PRRT. The study was conducted in 16 patients. As you can see from this example, there was a dramatic response and positive impact on the quality of life in this patient and the other patients, 6 out of 6 treated with 4 cycles, with an overall response of 83%, and no serious adverse event was noted. Dr. Ballal and co-workers in India recently published the results of their clinical trial with actinium-225 dotatate, another alpha-emitting form of PRRT. They published the results on efficacy, safety, and quality of life in 32 patients with advanced and refractory form of neuroendocrine tumors refractory to conventional PRRT. And partial responses were observed in 63% of the patients. And here you see an example of a partial response in a patient treated with 2 cycles of actinium dotatate. So we have explored the new approaches for neuroendocrine tumor theranostics, but how can we really move forward and make a difference? Well, we need to consider the principle of precision medicine, which is the administration of the right treatment to the right person at the right moment and in the right dose. So the first step as nuclear medicine physicians is to try and optimize the delivery of our treatment through the Symmetry. This procedure, the Symmetry, is the quantification of the dose of radiations that actually reach the tumor. And the idea at the base is that if we administer a sufficient dose of radiations, we may be able to overcome the resistance of the tumor and actually gain either stability of tumor responses. Obviously, we need to understand that there is no effect in PRRT without the dose. So there are some studies currently in our field aimed at tailoring the treatment schedule, so the Lutathera dosage, to the dose of radiations that actually reach the tumor in the hopes of achieving a good response, rather than doing the opposite, giving the same amount of Lutathera and then observing different doses. But I would like to stress how important it is to consider how the radiation acts. So the efficacy of the treatment is the result of a balance of the effect of the dose of radiations and the radiosensitivity or responsiveness of the tissue. So when we assess the response to radionuclide therapies, we need to consider the role of the individual tumor characteristics, which are determined by the genome. And neuroendocrine tumors are regulated by genes, and the relevant genes can be detected in blood as mRNA or transcripts or signatures. And so the measurement of these signatures in blood provide what we call a liquid biopsy for tumor biology. And signatures like the NET test can be used as a monitor to evaluate the course of PRRT. And we can also add another signature, which is called the PPQ, which functions as a predictor of PRRT efficacy when measured before the onset of PRRT. And so it is nothing else than a marker of radiosensitivity. So let's go in some details. So in a study, which was a prospective study on 3 independent cohorts of patients treated with lutetium PRRT, 122 patients, we evaluated the role of the NET test as a monitoring tool for PRRT. Let me take a brief step aside to discuss the monitoring tools available for PRRT at the moment. we use CT or MRI or functional imaging, but frequently we need to wait for the end of PRRT, after the end actually, 3 months after the end, to have a reliable assessment by imaging because of the risk of pseudoprogression in between cycles. So going back to our results in the NET test for PRRT, we can see that patients who, in the left curve, patients who exhibited a tumor response after PRRT had decreasing levels of NET test, which happened already during the treatment, whilst patients who exhibited progression of disease after PRRT had increasing levels of NET test during the treatment. And here on the right, you can see the modified waterfall plot with individual NET test results. And the patients who responded to treatment had either a decrease in the NET test values or persistent low NET test values, whilst patients who progressed with PRRT or did not respond had either an increase of the NET test levels or maintained high levels. So we did more. We developed a PRRT-specific predictor of response with which we can say that a new era of personalized PRRT can begin. This is called the PPQ, or PRRT predictive quotient, and it's derived from just the signaling and metabolomic genes circulating in the blood, integrated with the Ki-67 grade. And this has been tested again in 3 prospective independent lutetium PRRT cohorts and demonstrated a 95% predictive accuracy. Let me show you the details. So we tested the signature in 158 patients divided in 3 independent cohorts from Italy, from Germany, and from the Netherlands. And you can see that the patients who were predicted to respond to PRRT, the blue curves, had a much longer progression-free survival than the patients who were predicted to fail, who had a very short, unfortunately, progression-free survival. And the predictive accuracy, again, it was 95%. So for the future, we need to make sure that we consider the genomic profile of the tumors and the normal organs in order to predict the response and toxicity to PRRT. We recently reviewed the field, and we can say that both the response of the normal organs, which is the toxicity, and the response of the tumor, which is our efficacy, are regulated by genes, which we need to study in order to improve our treatments. The appropriate therapeutic to be used in the future will be calibrated on the symmetry and the genomic analysis of the individual genetically driven tumor and target organ sensitivity. In conclusion, PRRT has been accepted in the clinical algorithms of the major scientific societies and is now approved for gastroenteropancreatic NETs. There are still questions that need to be answered: when to initiate PRRT, how to assure that PRRT will be effective, when, if, and how to appropriately administer PRRT, how to improve the treatment delivery. We need prospective trials in all the new scenarios to establish the role of the new strategies, but we need, first of all, to have respective trials to establish the role, the position, and timing of PRRT in the treatment algorithm of neuroendocrine tumors. But I would like to stress that in the future, we need to make sure that we will not take a chance, again, with the treatment administration without stratification and then assessing the outcome afterwards. Molecular predictors will be required to assess feasibility and monitor efficacy and tolerability. Molecular genomics, such as the liquid biopsies, for example, the NET test and the PPQ, in conjunction with imaging. Finally, I would like to acknowledge my team, the MITS radionuclide therapy team at Memorial Sloan Kettering, the MSK neuroendocrine tumor teams, particularly our GI oncologist and interventional radiologist. I would like to thank my collaborators from Yale and Rennes, Professor Modlin and Kidd, and I would like to thank you very much for your attention.
Thank you, Dr. Bodei, for joining us again today, and thank you for that excellent presentation. I know I learned it a lot, and I'm sure the whole community does. And I always learn so much from you. It's so exciting to hear. I mean, I can say this because, as you know, my husband's a patient too. And you and I have had many conversations about, PRRT just specifically or generally, and I've learned so much from you in these talks. And as a patient or in the patient world, sometimes we can get focused on like one thing, like there's only one way, or feel very overwhelmed. And it's exciting to see, as you described, where we've come already. So that's encouraging, where we are now, and all the work that's being done, and where we're going to go. So thank you for that excellent overview. So we have a lot of questions roll in, so I'll just get started with the first one. There's a lot of questions about who's eligible for PRRT. So if you had radioembolization Y90 to the liver, would you still be eligible to have PRRT?
I would consider how many treatments have been administered with a radioembolization, the dose that has been administered to the liver, and the liver function, the aspect of the liver within, at imaging. I would discuss the case within the dedicated tumor board. And if the liver function is preserved and the prior irradiation of the liver has not been excessive, I would still consider PRRT. As I mentioned in the talk, in Europe, where traditionally patients arrive to receive PRRT in a much earlier phase, there are no such reports of excessive toxicity when patients receive a combination of both treatments in sequence.
Thank you for that. Thanks. That's helpful. And another question is, well, what's the effect of delaying a treatment of PRRT once it's started? That is, how long can one go before, say, the second treatment of 4?
That's a very good question. All of them are. So generally, we establish this rhythm of 8 weeks, which is the classic NETO1 style kind of rhythm of administration. So 8 weeks, 2 months between cycles. But a lot of experiences in Europe have been conducted with longer intervals, like 3 months, and the data demonstrate efficacy and unchanged efficacy, and also the NETO1 trial, or for that matters, the schedule that has been approved by the FDA mentions the possibility of elongating the interval should there be any toxicity or clinical needs, and generally it is considered that an interval of 4 months can still be acceptable.
Yeah, okay. I think it's, on the patient side, there can be a lot of anxiety when you're told it's going to be on the schedule and then it's delayed. But you're saying that it can be okay.
Yeah, radiation has a summation effect. As I always say to our patients, radiation leaves memory, and that's why we add one treatment on top of the other. So obviously, okay, we need a certain rhythm, but we can afford slightly longer intervals without any problem.
Okay, there's no negative effect for delaying. There's a lot of questions about who's eligible, and I know you went through some of it, but is anyone doing PRRT for grade 3 NET and NEC for patients that don't have somatostatin receptors? And if so, what makes you a good candidate for this treatment?
Yeah, that's a very important point. So, as you know, G3 well-differentiated neuroendocrine tumors are treated, especially here in the U.S., where our label can allow us to do such treatments. G2 and G3 neuroendocrine tumors are the object of the currently ongoing NETO2 trial. As to the neuroendocrine carcinomas, which are the less differentiated neuroendocrine tumors, generally they do not constitute a good candidates because of the lack of somatostatin receptors. So one of the main rules of PRRT is that we want to treat a disease which we can reach wherever it is. So generally, the presence of lesions which are not positive, that don't light up on gallium directate PET, do not make for good candidates, because in that case we would treat disease and we would leave untreated those PET negative disease. So we want to have, generally speaking, we want to have homogeneous disease which can be reached by our pharmaceuticals wherever they are. There are some exceptions that obviously have to be discussed within the dedicated tumor board in case of single lesions that can be addressed with other techniques, for example, liver-directed therapies, but these are obviously exceptions. We don't want to administer radiation and then not be able to control all of the lesions.
Mm-hmm. Mm-hmm. Like you said, we see what we treat and treat what we see.
Yes.
But just out of curiosity, now that we have the copper-64 dotatate, would there be any reason if someone had a gallium dotatate to image again with a different type of somatostatin receptor imaging?
Why not? Obviously the experience with gallium dotatate or dotatalk, more common in Europe, has been going on for over 20 years. Copper dotatate is a little bit more recent, but the data from Denmark, first of all, and also here from the US, show us that we can image small volume disease and possibly discover more lesions than the ones that we can see with the gallium dotatate. Obviously, we need more experience to test the tracer in the real world condition. But why not? Mm-hmm. That's my answer.
Why not? Okay, thank you for that. So, is there evidence how effective PRRT is for different type of net primaries, such as the colon, rectum, and appendix?
Yeah, that's a very good point. So obviously we like to have what we call randomized studies. So we want to test PRRT versus something else to decide, the benefit. But there's only a certain number of randomized studies that one can conduct. So we have to look at our single arm, as we call them, or single group studies. And thousands of patients have been treated in Europe and in Australia. And we know that single types of neuroendocrine tumors tend to respond differently. For example, pancreatic neuroendocrine tumors tend to respond more, tend to have greater response rates than, for example, small bowel neuroendocrine tumors or bronchopulmonary neuroendocrine tumors.
Okay, and that was a question too. How effective is PRRT in treating advanced lung nets, and has it been approved in the US for use?
That's a tricky question. So as I showed to you, bronchopulmonary neuroendocrine tumors exhibit the same efficacy when treated with PRRT as gastroenteropancreatic neuroendocrine tumors. So PRRT is really a valuable option in this type of disease. Despite the fact that, as I said, PRRT is approved in gastroenteropancreatic neuroendocrine tumors, technically bronchopulmonary neuroendocrine tumors are what we call foregut neuroendocrine tumors, and most importantly, the NCCN guidelines in 3 different iterations in the past years have recommended the consideration of PRRT in this group of patients because of the reported efficacy.
Mm-hmm. So hopefully with the guidelines, they might be able to get it. Mm-hmm.
Yeah, and we get it sometimes, but it's it's a little bit scant at the moment.
Yes, thank you for that. This is a follow-up to some of your comments about the SIRT. So would you explain more about the relation between SIRT and PRRT with the timing of the use between the 2 therapies?
the relationship between SIRT and PRRT. Well, they are two forms of radiation. One is a radiation delivered directly to the liver in the forms of radioactive spheres. And the other one is a form of systemic treatment, so which will go to the liver and also to the other organs. That's the main difference. The timing of the use, it's a great question, because at the moment the decision is left to the individual tumor board. Generally, we tend to prefer SIRT in case of liver dominant disease or liver disease exclusively in the liver, maybe with a not a great uptake at the net spot PET. In that case, we prefer to deliver radiation with SIRT. And whilst patients with disease in the liver, but also elsewhere, tend to benefit more from systemic therapies such as PRRT.
Okay, thank you for that explanation.
I hope I answered the question.
I hope so too. How will we handle the current shortage of amino acids?
Yeah, I read about it. In our hospital, we compound the amino acid in our pharmacy. So that's a solution. How to handle it? So obviously we need some lobbying activity towards central pharmacies and possibly agreements with different hospitals to try and see if there can be an exchange of material. Obviously, this is not ideal and not easy to do. The compounded amino acid in the central pharmacy is possibly the best way to go and the strategy to pursue.
Yeah, that's probably helpful that you're compounding your own.
Yeah.
So there's a lot of questions also about the side effects, right? As you kind of mentioned, have you seen that patients who get MDS or AML, so myelodysplastic syndrome or acute myelotoxic lymphocytopenia? Oh wait, am I saying it right?
Leukemia.
Are more often leukemia, acute myelotoxic leukemia, are more often male or female or male, younger versus older?
So that's another very good question. So obviously, fortunately, we don't have a great census on these very untoward events because they are rare. Fortunately, they are very rare. A few years ago, when I was at my prior institution in Milan, we conducted a study on 800 patients and we evaluated the frequency of these events in our population. And we tried to understand whether certain characteristics of the patients and of the treatments that they had received had an impact. Gender didn't have an impact. Age didn't have an impact. We had, unfortunately, patients of all the ages. We thought that chemotherapy was the main cause, instead of which we found out that, yes, prior treatments could explain statistically a part of these events that we had observed, but a large sector of our patients had no explanation, and so we had to conclude that there is a individual susceptibility that we have to consider.
And another follow-up question, is there a particular blood type that's susceptible to the occurrence of lymphoma that I think they mean leukemia, that a small percentage of recipients get after receiving PRRT?
Not a particular blood type in terms of A or B or AB or 0. What what one can observe is that in these patients who eventually, years after the treatment, end up with this complication, it's frequently we frequently observe a drop in the blood cell counts, and which is hard to explain and does not improve even if the treatment with the PRRT was done a while ago. And then we start investigating with our hematologists, and then we discover that unfortunately there is this complication. But, as said, this is very rare. It's important to note that. It's important that everybody, first and foremost, the patient is aware that there is this risk, but fortunately this is not very frequent.
Mm-hmm. And this question has come up a lot in our support group. I know naturally patients would wonder what precautions are there to protect against this rare complication of bone marrow toxicity.
There are no precautions. I think the best precaution is to have a neuroendocrine tumor team, a tumor board, and a good nuclear medicine team, and to be aware of of these events. And sometimes if we see that the treatment is resulting in moderate or severe hematological toxicity, we consider halving the dose or stopping the treatment. So I think attention and care to the side effects during the treatment is probably the best precaution at the moment.
Mm-hmm. Mm-hmm. And that's definitely done with a multidisciplinary team.
Yes.
Someone who has experience like you, definitely. Mm-hmm. Yeah. And, again, this is a concern on people's minds. So PRRT can be really hard on our immune systems. How many weeks and months post-PRRT does it take to restore the white blood cell and neutrophil counts?
Okay, that's an important question. First of all, it has been demonstrated. We demonstrated when I was at my prior institution that there is no increased incidence of infections or infectious diseases after PRRT, during or after PRRT. A lot of the patients usually get a little bit scared because of that drop in the lymphocytes. And they usually say, well, am I at risk? We studied, when I was at IEO in Milan, we studied which types of lymphocytes are affected by PRRT. And we found out that they are not the lymphocytes that are commonly involved in our, defense. They are the B lymphocytes, obviously very important, but they are not completely depleted. They are decreased. So, generally this doesn't mean that we are at risk for infections. Now, we do observe a drop in the white blood cells and the neutrophils. Generally, the drop is mild in the majority of cases. In a small percentage of patients, this drop may be more pronounced, but very rarely do we need to intervene, and very rarely we have a severe depletion in the neutrophils and the white blood cells. And generally in these cases, we space out the treatments, or we decrease the dosages, or even we discontinue the treatment. And generally, it has been demonstrated that within a few weeks, generally 6 to 8 weeks after the end of treatments, the counts start to go back to normal. Obviously, there is a summation effect. So the count drop that we observe after the fourth cycle is generally deeper than the one that we observe after the first cycle. But generally the recovery times are the ones which are included in the normal interval of 8 weeks. 8 weeks. Generally, they are enough.
So generally, it should bounce back, and it's helpful to know. I think it's reassuring to know, especially during the pandemic, I'm sure you've received many questions from your patients and other people about whether or not they're more susceptible to COVID and other infections.
Yes, that's a very good point. We discussed a lot. Obviously, nobody had the answer because nobody knew this terrible disease beforehand. But whilst also in discussion with our infectivologists, we didn't think that PRRT could pose a threat of a more severe COVID disease or more susceptibility to COVID disease. Obviously, we don't want to treat patients with active infection.
Mm-hmm. Mm-hmm.
We don't want to
so
have
just out of
the discomfort of the PRRT, possible discomfort of PRRT on top of the infection. So we want to treat patients who are stable.
Yeah. So if someone has active COVID, it's not a reason to treat. You don't want to treat them. But just curious, through the pandemic, have you continued to treat with PRRT?
Yes, we did. We did, and in agreement with our team, with the GI oncologist, in agreement with our infectivologist and the leadership of our hospital. Yeah, we obviously tried, like everybody else, to be wise, and we wanted to continue the treatments of those patients who risked more from absence of treatment than from COVID, and obviously try to space a little bit more, especially in the first more acute phase here in New York.
Yeah, when you were in the epicenter.
But it was a tough decision. We worked with our oncologist, with Dr. Reedy, Dr. Raj, Dr. O'Reilly, case by case, and we decided what was best for each one of the patients.
Mm-hmm. Thank you for that. Thanks for that. Because I'm sure the patients really needed it and we're grateful. I've talked, and I know that there are people in our group too, people who have only been able to complete 3 for various reasons. So have you had experience with patients who are only able to receive 3 PRRT treatments?
Yes, it doesn't compromise the efficacy of the treatment. So first of all, the number that we put to this number of treatments, or the number of millicuries that we put, is not fixed. It's a range, and it was demonstrated long ago that the range of minimally efficacious radioactivity is 600, sometimes even a little bit less than that, from 600 to 800. So it's a convention that we aim to give 4, but 3 good treatments may be equally effective. And sometimes we have to stop in order to preserve the bone marrow or the kidney function of the patients, but the treatment may be equally effective. And as we usually say, we want to treat the patient, not just the disease.
Yes, for sure. We want to treat the patient. That's the most important thing. So let's talk a little bit about surveillance. Post-PRRT, do you recommend quarterly, every 6 months, or annual follow-up to check with scans to follow up for progression? And do you recommend the NET test at the same intervals?
Okay, so there are a lot of questions. So what type of follow-up? So as we know, as I said also during the talk, PRRT acts by giving a radiation inflammation. And in most cases, this radiation inflammation results in a sort of swelling, which sometimes results in an increase in tumor size. So that's why we tend to avoid imaging in between cycles for the risk of what we call pseudoprogression, which is not super frequent. It's like 10-20% of cases. But certainly when we image in between treatments or too early after the end of treatments, we risk of not having the full picture of what we have gained with PRRT. The same goes with biomarkers like chromogranin A, although nobody uses chromogranin A to make any decisions. But if one were to check chromogranin A in between treatments, the results would be all over the place. And it has been demonstrated that, regardless of what happens at the end, after the end of treatments, chromogranin A values can be increased, stable, or decreased, and they don't predict what actually happens. So we usually check the response of PRRT after 3 months, 2 or 3 months, depending on the, let's say, aggressiveness and the grade of the tumor. And then we like to have both CT or MRI, depending on what the parameter exam is. We like to have a gallium directate as well. And then, if there is a benefit, which is at least a stable disease, after the end of PRRT, we normally continue to check with only morphologic imaging, so CT or MRI, and generally this is done by the referring physician, and they continue with a rhythm, for example, every 3 or 4 months, or if it's a very indolent disease, one can probably elongate the interval to 6 months. And the NET test, as I showed in my presentation, in the patients where we tested it, we demonstrated to be very useful because it starts to go down during the treatment. So it's a useful tool to follow these patients and have an idea of what's going on, and if we have to be more aggressive, or if we have to check more frequently, or maybe start thinking of integrating another treatment because what we have is not being very effective. So and obviously, if we are having images, the NET test makes sense. But the advantage of having a blood test is that it doesn't necessarily have to come with all the images. You don't have to image every 2 months, for example, whilst you can have a test more frequently than the frequency of imaging. And a few years ago, we demonstrated in a registry study that in patients treated with somatostatin analogs or other treatments, or non-PRRT, or watchful waiting observation, we demonstrated that the clinicians felt reassured by the NET test values, and decided to elongate the intervals between imaging in those patients where the NET test was low or decreased, and the follow-up demonstrated that they were right to do so.
Yeah, I remember hearing you talk about that registry study, and that's just fascinating.
Yeah.
Mm-hmm.
Yeah.
A follow-up question about the imaging is if extensive liver mets are a critical factor and an MRI with contrast provides the best liver imaging, why use CT scans to measure progression post-PRRT?
Well, it's another, there is, so MRI has the best sensitivity, we know that, but it's not that the sensitivity of CT is greatly lower, and there are certain types of disease, certain extent and sizes of disease which are perfectly imageable also with CT. That's why each patient has their own parameter imaging technique that is generally repeated, and it's adapted for that type and extent and of images. And generally with CT, we also get a very good image of the lungs, so all the images are provide complementary information.
Yes, thank you for that. And a follow-up question for the NET test: how does the NET test work with PRRT, and is it possible to repeat PRRT? Oh, that's a separate question. After the initial 4 treatments. Well,
we discussed how the NET test works with PRRT. We just said it in one of the recent questions. So as I also showed in the talk, the NET test seems to follow the final results of the PRRT already during the treatment. So it's a valuable tool to monitor PRRT and obviously to add to imaging when imaging is performed. As to the question whether it is possible to repeat PRRT, yes. Although this is a less charted territory, but we are getting more and more data about re-PRRT, as we call it. There are many data from Europe, and we are getting a lot of experience also in the US. What we know is that it is feasible. We like to repeat PRRT in those patients who have gained a benefit after the primary treatment and in whom the benefit has some duration. So if a patient has a tumor shrinkage after PRRT and that this shrinkage lasts, for example, for a year and a half or 2 years, that's a good timing. We like to wait at least 1 year. If there is progression too soon after the end of PRRT, maybe PRRT is not the best option for the patient. And the NET test, in our series of patients that we treated in Europe, we had in the Italian cohort, 1/3 of the patients were at the retreatment, and the NET test functioned well also in the retreatment.
Thank you for that. And for, I put up that next question because it was exactly what you're talking about. And someone also asked that. And for whoever was asking, as you know, Dr. Bodei, my husband was retreated because he had a 3-year duration and a very good response. So it is being done out there. And this kind of goes to the next question. How much time are we from using PRRT for salvage or neoadjuvant therapy?
How much time are we from using? So we are already using it for salvage, and for neoadjuvant, not so frequently, at least not here. In Europe, there is some experience. As I said, the Netherlands and here and there, everybody in Europe has some experience in treating patients with either inoperable or borderline inoperable pancreatic neuroendocrine tumors. As I said, the Italian Neuroendocrine Tumor Association is initiating a prospective protocol where they want to see exactly, how many patients gain that benefit of operability.
Thank you for that. Now, there's a lot of questions about what's on the horizon. So the antagonist study that you talked about with JR11 does look promising. Where can someone receive this? And have you continued on with that trial?
Yeah. So we have not, although there is some plan for the future. The trial continued with a company-sponsored trial, which ran mainly in Europe and Australia. At the moment, the trial is complete. We don't know of any other developmental plans, but JR11 is just one of the class of somatostatin receptor antagonists. There are other antagonists that have been developed, for example, in Germany, which could reach the horizon and the horizon of diffusion worldwide, not just in Germany. So we are hopeful because it's a very promising class of pharmaceuticals.
Thank you for that. And a lot of questions about alpha. So what's the proposed use of the newer elements, in quotes, like actinium and lead in PRRT? Would that be a major advance or simply fine tuning?
We don't know. What we know, obviously, we have to test. We have to conduct trials. And trials are ongoing already. We saw the data from Dr. Del Passan, and I know that Dr. Del Passan gave a lecture a while back. Let's say the important finding is that this type of PRRT with alpha emitter, so with very strong radiation, seems to work well also in patients who are refractory to conventional PRRT. So that's obviously a very hopeful sign.
Thank you. Thank you. And that was another question too. If someone undergoes a beta, so Lu-177 dotatate, a PRRT, is there any reason the patient cannot participate in future treatment with an alpha emitter therapy?
So technically, in terms of intellectual, no, let me say, there is no reason other than the parameters of the study. So if the study accepts only what are called naive patients, then maybe not. But this treatment, when was made available to patients who had already received lutetium PRRT and had progressed to it, was efficacious. So hopefully we will have such the possibility of enrolling also patients who have progressed onto conventional PRRT.
Fingers crossed, because we all hope, and we need to hope. So
we do.
Yes, we need that hope. And this is an opinion question, of course. Do you think alpha therapy will replace beta Lu-177 based PRRT in the future?
Well, I need the glass sphere. I think, well, I think in some indications it may, and in some uses it may. There are some data from Germany again, who the group from the University of Heidelberg. They tested it intraarterially, and it was very, very effective in patients who had progression to every kind of treatment. So we are very hopeful on alpha emitters, very, very hopeful, especially if we can target them and we can protect the normal organs. We are very, very hopeful, because the type of radiation is a type of radiation that is much more effective on the tumor cell, on the DNA of the tumor cell, than our lutetium PRRT.
Thank you. That actually answers one question that came up. If you could talk about the benefit or the risk of alpha versus beta emitter.
Well, briefly, the benefits, the benefit we already discussed. The risks are the usual risks of PRRT. We don't have a head-to-head comparison to understand whether the risk of, let's say, hematological toxicity, so a drop in the blood counts, is deeper than with lutetium PRRT. Obviously, because the experience is still limited, we don't have a census on the occurrence of the very untoward events such as myelodysplastic syndrome. Hopefully, the very targeted radiation will be actually a protective factor, but we need to have more data.
Mm-hmm. Thank you for that. And for those watching in the audience who are just hearing those words now and don't know what alpha or beta emitter are, and they're just wondering about this, last month's webinar with Dr. Delpasan would be a good one to watch. He has some nice visuals to go along with that. And this is an interesting question. What's the significance of using the different elements such as lead and I guess actinium and other ones in PRRT?
They are different flavors of the type of radiation. So, it's a matter of the chemistry team that one has available, and what we want is a type of alpha radiation, which is the strong radiation, which is stays enough on the target, but not too much that creates problems or has a lot of, let's say, byproducts of radiation that might create problems on other organs. So there are different flavors of the same approach.
Thank you for that. So there are several questions on timing, so let's just take a couple before we close off. Any evidence to say that PRRT before somatostatin analogs, so as first line, could be helpful for some?
Well, as you may recollect from the talk, there is a study which will hopefully establish that. So in Europe, where PRRT has been going on for 25 years, the doctors tend to refer patients for PRRT much earlier. In some cases, even upfront, but there are no clear data on that. So we really need a randomized study to understand the potential.
Thank you. There was actually another question about the opposite, if it's not useful, if it's administered early as the first line, if it's, I guess, detrimental in any way.
I think as any therapy, but particularly PRRT, it has been demonstrated that it's more efficacious if it's administered earlier. It's not always possible. There are unfortunately patients who are discovered with high burdens of disease. But in general, if we can treat patients sooner, the treatment tends to be much more tolerated and more efficacious.
Maybe we get more bang for the buck, right?
Yeah.
Someone's wondering if you mentioned timing with PNETs and liver mets, but not midgut. How's that difference with or without liver mets?
I guess everybody got very comfortable with the results of the NETA-1 trial, which was conducted in midgut. And now everybody knows, and it's, before we used to get very end-stage cases. When I started this kind of treatment over 20 years ago, we got referrals of very end stage. Also, I remember several dear patients who were referred with small bowel neuroendocrine tumors referred when they were unfortunately very advanced. But now, thanks to the NETA-1 study, we know that if somatostatin analogs fail, PRRT is generally considered. But I say generally because the tumor board has a lot of importance. We always need to check where the progression is and if there is any role for direct liver therapies before PRRT. It's always a team approach.
Yes, again, multidisciplinary tumor board is very helpful, the team approach. We'll just take two quick ones. So someone has had 4 sessions of PRRT 2 years ago and doing another 2 now, but why are we limited to 6 in America, but in Europe you can do many more treatments?
As I said, when we retreat patients with PRRT, we are in a sort of uncharted territory. There are some data that are coming out, particularly important, the data from Rotterdam, from Erasmus University, who was, the place where this treatment was invented. They demonstrated that additional 2 cycles are effective and well tolerated, and additional 2 cycles are effective and well tolerated in obviously, this is generally a small fraction of patients. So it can be administered. We like to not to administer another course of 4 cycles. We like to divide it in 2 and to check the first 2 cycles and to evaluate whether it is necessary, efficacious, and well tolerated before proceeding with another 2 cycles.
Mm-hmm. Thank you. And we'll take this as a last question. This might be kind of tricky, but you mentioned the sweet spot for PRRT. So when do you think is the optimal timing? And I know there still needs to be study done on that. And who are the best candidates for PRRT? And how do you go about deciding which one or ones?
Well, obviously, it varies according to the local experience of the tumor board. But let's say some general rules. Patients who are directed towards PRRT are patients who are in need of a systemic treatment, so a treatment of the tumor throughout the body. Patients who are in progression, generally we like to wait for progression of disease. Increased disease, patients who have a positive net spot PET, gallium directate PET, patients who do not have negative lesions, negative disease at the net spot, who obviously would not benefit from the treatment. And then obviously in the tumor board frequently there is a discussion whether we could do some liver-directed treatment, as the majority of lesions are generally in the liver, or whether we should do, PRRT. Sometimes, disease progression can be taken care of, with a local regional treatment. Sometimes we decide for a systemic treatment, especially if there are extra hepatic lesions. But the optimal timing is generally after progression to conventional therapies. Progression of disease doesn't necessarily have to be resist progression. Can be clinical progression, bulky disease, increasing disease, symptomatic disease, patients with functional tumors where the syndrome is hard to control.
Okay, so systemic progression and a team decision, sounds like. Well, thank you for all that. I mean, we went through so many questions. I think there were over 20 questions that you answered. And I just wanted to thank you for this really great overview, like a bird's eye view of the past, present, future, and all the exciting work that's been done that you have done. And that just really gives us all hope. I just want to thank you from the bottom of my heart, because this means so much to all of us in the NET community. Thank you. And with that, thank you so much. With that, I'll have you, Lindsay, go ahead and take it away. Back to you in the studio, Rich.
Thank you, Lisa and Dr. Bodei. As a reminder, please be sure you're following LACNETS on social media. We have a Facebook, Twitter, and Instagram. You can stay up to date on upcoming webinars and NET news. As a reminder, today's webinar is being recorded and can be viewed on our YouTube channel shortly after the live broadcast. Now back to you, Lisa.
Thanks, Lindsay. We understand that these may be challenging times, and we offer many programs and resources, including our weekly NET support group, our monthly NET caregiver-only support group, NET Vitals, which is a downloadable patient-physician communication tool to help you prepare for your upcoming medical appointments, and health coaching that is available to either NET patients or caregivers. We encourage you to go to our website to find out more about our programs, view resources, read blogs, and take the NET quizzes to check your understanding of all the information that you've been taking in, and much, much more. We have many exciting upcoming webinars, and I'm really happy to share with you that we've confirmed all our speakers for the rest of 2021. Let me just share with you a few of them. In May, Dr. Aman Chauhan will be joining us from the University of Kentucky to talk about clinical trials, the latest and the greatest in NETs. That meeting will take place on a Saturday, May 15th. In July, Dr. Eric Liu will be giving a talk called It's a Marathon, Not a Sprint. In August, Dr. Chandrika Chandrasekarian from University of Iowa will be presenting on treatment selection and sequencing in NETs. We're pleased to have the CEO of the nonprofit Triage Cancer join us in October to talk about navigating health and disability insurance. We're also excited to unveil our incredible lineup of speakers for our virtual 2021 LA NET Patient Education Virtual Conference, and to share that our registration is open. Thank you again, Dr. Bodei, for your excellent overview of PRRT 3 years after its introduction to the US, where we are and where we're going. This is such a message of hope and a great understanding for us to know that we have many more options and we have a lot of things to be excited about that are coming down the pipeline. Thank you also to Rich from TVP Live, and thanks to all of you for joining us today. See you in May for our next webinar. Bye.